So let's dive into some questions. Let's go for an easy one first, and I shall ask Shruti first. How confident should clinicians be to reinfuse potentially contaminated blood from a medical negligence, legal or clinical governance perspective? I thought we'd start with a simple one.
That's hardly simple, and I'm not an expert on that. I think it is the cell salvage experts who would need to come in and answer that question, Craig. Thank you.
But perhaps from a governance perspective then.
No, I think as with any other practice, as I said, I mean, I'm not a technical expert from a cell salvage, and it is actually, looking at the evidence, what is the evidence telling us, and actually, is that safe to proceed? And also, it is actually always with any kind of a transfusion, whether it is allogeneic setting or the autologous cell salvage, it is a balance of the benefit and risk. And I think if it is, like we heard an earlier presentation about the vaginal cell salvage now, it is an innovative one. It started off because of the need. So I think it is, I may not be answering the question directly because I think I would ask our experts to come in, but I think ultimately it is, are there any other alternatives available or safer alternatives available? In the lack of that, are the, benefits outweighing the risks? I think that would be my way of thinking, but I think others could come in, please.
And I guess what we really need is denominator data, isn't it? And proper reporting, as you mentioned. So you've handed the baton over to our obstetric team, and we could perhaps ask our obstetrician first of all. Joe, what do you feel about doing something which is fairly cutting edge with, let's say, with vaginal collection?
I think we're in a position with vaginal collection that we were when we started bringing in abdominal collection. Initially, everybody was very concerned about the amniotic fluid, and I think that I think there was a difference between collecting blood vaginally during a cesarean section when you've prepped before, the area is clean and as sterile as it can be, so you sort of set up a bit like if you're doing a hysterectomy. That is a very different kettle of fish that even if you've prepared, so we've got a Jehovah's Witness that has been prepared and has had antenatal counselling, that has had a vaginal birth and say forceps or something, and then there is much more likely to be fecal contamination, etc. in that is a less clean thing. So I think that there is a difference between vaginal cell salvage after an abdominal delivery and vaginal cell salvage after a vaginal birth. So I think those are two separate things that when we're looking at it need to be looked at. But again, I think what is the alternative? And so it's a risk benefit thing. So yes, I feel that it will come. It needs to be done properly. The setup needs to be done as structured as possible. But I suspect that in the next 5 years, it will be much more standard. You're balancing risks, aren't you? And we're balancing risks all the time. But if 8% of women are having a blood transfusion after an operative delivery, vaginal birth in theatre, then it's the balance of that versus the women. I think will want their own. That's what women
the difficulty is that we can reliably give the data about what the risks with respect to a donor blood transfusion is, but we can't necessarily do the same at the moment with vaginal collection, let's say, or any other controversial a bit. Catherine, have you got anything you'd like to add about that, about the consent that you do as the anaesthetist with respect to that cases like that?
I guess the main thing to reiterate is that our vaginal cell salvage policy relates to women who have no safe alternative, which does hamstring us somewhat because we're never going to collect the data if we're never going to use the procedure. So it's been great to have the data from the States published. It's possible that we will see more women not wanting to have blood transfusions. Recently, post people getting COVID vaccinations, we've had some members of our population say that they don't want to receive blood for that reason. They don't want any potential vaccine contamination. And that is coupled with our obstetric population getting more complex and having a higher PPH risk. So more opportunities may present themselves in the future. a key, I think, a way you can protect yourself is to always follow your own protocol. Having said that, I have just presented a case where we did deviate from our own protocol, but it did help this patient's outcome. But yeah, the numbers at the moment are not big enough to reassure me greatly, but it's good that we have some numbers.
Right. So for our two protagonists of the debate, here we go. So what do you think about an HCA being involved in setting up and even processing the self-salvage, or being involved in the machine processing?
Caroline, do you want to go? Or
we use heparinized, so we put in the heparin in our saline bags rather than use ACDA. So anything to
sorry did I say, I meant to say an HCA. Do your HCAs get involved in setting up the machines?
No.
Anne-Marie?
So personally, they don't, but I know across the region there are many trusts that do use HCAs. And I think as long as there is appropriate training, like I've said before, and a good training structure, also the support of trained registered staff, so checking ACDA fluids, it would be checked by a registered member of the team, then there's been no incidences of issues using an HCA difference to that of using a registered practitioner. So it's down to your own governance, I suppose, in your trust and your training structure that you have. But some people have found it a really good, reliable source of cell salvage.
Okay, and a quickie. Do you all use heparin or ACDA in your swab washes? Yes,
ACDA for me.
Caroline?
Saline, and we suck it straight up as soon as it's going in, it's coming straight out.
Obstetrics?
Yeah.
Okay, right. In obstetrics, do you use a single or dual suction? Anybody?
I can answer that. So we would usually have a suction to try to the Lycal, so to just take it out the operative field, and then the cell salvage suction. But in our higher risk ones where we are going to go straight through the placenta and know that we're potentially going to lose 2 litres in the first 2 minutes, it'll all go up. So the Lycal will all go up with the blood.
Okay. Oliver, have you got anything to add, or Anne-Marie, anyone on that? Anne-Marie?
Probably just to say again, the evidence out there is a paper that was done previously where they looked and there was no extra contamination by sucking amniotic fluid into the reservoir. So there is some evidence out there to suggest that is practice. Catherine will obviously come in with that because it was at your hospital, but yeah. So it depends on your specific SOPs.
Catherine, do you want to come back on that?
Yes, I'm afraid it was published by my predecessor, Dr. Ralph, but on that basis, we use single suction, but we do a double wash in obstetrics. So I think that might be the difference in some places where they do a single wash. We do a double wash, but we only use a single suction, and all our in-house QP shows that AFP, which is our surrogate for amniotic fluid, is always removed by the washing process.
Shruti, do we know which model produces more adverse events, a single practitioner or a dual role?
We don't have enough data, and I think because not all the questions in our questionnaire are not mandatory as well, we may not have that information. So I think as I said, I think this forum hopefully would also prompt everybody to actually then report better. I think once we get more data, we may be able to look into that and get back to you.
Okay, right. Now I'm going to go some really simple questions now. What's the minimum volume that we should bother processing? Ollie?
Well, I think that depends on what machine you're using. I would never aim to set up cell salvage if I thought I wasn't going to get a full bowl. We use a sort of bowl orientated cell salvage machine, and you choose the bowl size when you decide to process. The manufacturers won't vouch for the quality of blood that you're getting back from a partial bowl, so I'd never aim to set up a cell salvage circuit if I thought I wasn't going to get a bowl. What the minimum that I would then reinfuse to a patient is going to be governed by the bowl size. But if I've gone through the process of processing the blood and it's available, the audit data that we've got from our experience of cell salvage is that the salvaged blood is very safe to give back to patients. So if it's there, if it's available, if I'm convinced that it's good quality, then I'll give it back to patients.
Okay. Has anyone else got any thoughts on that? Before I then double down on an even more complicated version of that question. Right, let's go for the difficult version. Different machines give different hematocrits, different processing gives different hematocrits, accepting that sometimes people will reinfuse some partial bowls. Is the volume being reinfused the correct denominator or indice we should be looking at? Is there a better way of looking at how we're affecting reinfusion?
Probably there is a better way, but is it readily available? No. I think realistically, if you're looking at what you're infusing back to patients, you're infusing back red cells, and that's the important thing that we're giving back. It's the number of red cells. So if you had a way of taking the volume that you're giving back to patients, looking at the hematocrit, and coming up with a more standardized value, then of course that would be much more beneficial to measure. That's going to be the actual useful figure that you're reinfusing back to patients. So no, I think volume isn't necessarily the best thing to use. However, it's readily available. Most cell salvage machines will produce a volume of blood as they're processing and tell you what the total is. Not all cell salvage machines will produce a hematocrit. If you're processing multiple bowls, then you're looking at having to average hematocrits out over a long case, for example, and then suddenly you're having to do some sums and some calculations, and there's still an element of guesswork there. So yes, I think we could certainly do better, but is it readily available at the moment? Probably not.
So the answer then to that question is, let's keep it simple and let's get the data first off for a minimal data set, I guess. Certainly as I would go for. So, right then, some practical questions. How long can you leave a suck and see setup without using it before it becomes expired? Anne-Marie?
So again, guidance out there is for the same as blood transfusions, I believe. So, I think it's now my brain is going to go dead, but I think it's 6 hours. Is that right, everybody else on the call? Thank you.
What about some an emergency kit set up? How long can you leave that lying around?
So, we would leave a kit open for 24 hours in line with other sterile equipment that's been put in place. But again, I suppose that goes back to looking at manufacturer's guidance. But we would assess, especially in obstetrics, we would leave kit open and on standby available for a maximum of 24 hours, and then it would be changed.
Okay. In pediatrics, the circulating volume is lower, so washing a partial bowl is more likely. Are there any risks of doing this? Well, I could start off this little bit. First of all, depending on the machine you've got, sometimes you've got teeny tiny bowls. So if you've got the teeny tiny bowl set up, then that would reduce the risk. All of the bowl processing systems have got recommendations for the volume of wash and how often and whether you should use a double volume wash. And then the other thing is always looking at the quality of what you're just about to give back. Has anyone got any further points that they'd like to make about that?
I would add that it depends how full your bowl is.
Yes, of course.
The bowls are asymmetrically filled, so it doesn't take very much blood for the volume of the bowl to appear to go up by about half, but that doesn't necessarily correlate to a 50% filled bowl. And I think the other thing is having confidence to infuse partial bowls back to patients. So in our hospital, our previous cell salvage machines, we did a lot of QC sampling, and so while the manufacturers didn't recommend the use of partial bowls and wouldn't guarantee the quality of the products, actually what we found is that if you're around about 1 centimetre or so from the top of the bowl, and you wash that as normal, then actually the quality of blood that's coming out of that bowl is very comparable to what's coming out of a full bowl. And so we advocated, if there was need for patients to receive blood, then a partial bowl would be acceptable.
Okay. Another quick practical question. Has anyone within the group had experience of laparoscopic cell salvage?
I'm happy to answer that one. If anybody, we do at North Bristol, and basically the aspiration line for the cell saver, just you do not use that. You use the laparoscopic suction, which then attaches straight onto your reservoir, and you can feed ACDA or heparinized heparin with saline via the top bungs of the reservoir, just from a normal giving set. So your aspiration line isn't anticoagulated, but the reservoir is anticoagulated, and that's how you get around it. The only thing to say is that the suction levels often aren't high enough for that of what the surgeons need, so that can be a little bit of a factor in it, because obviously they wanting as clear a vision as possible, so they want the suction quite high. But obviously if you have your suction too high, then you are obviously going to damage the cells, so we would still advocate using like a smart suction approach.
There's a question sort of going alongside that. Someone's requested advice on placenta accreta, in that when the rate of blood loss is so great, is cell salvage obsolete? And I suppose that would also be a question that went for patients with IVC injuries or large vessel bleeds. I have some experience with this, but would any of the group like to raise points on that?
I mean, I'll go on. I'd just say cell salvage is vital in those situations, is probably what I would say from my experience. But go on, Joe, I'll let you talk.
I would say that so sometimes we have 2 machines. Very occasionally we've had 3 machines working simultaneously. I think the key is massive communication between the surgical team and the cell salvage team about when you need your suction, when you don't need your suction. So if we're in a bit where it's bleeding loads and I need to be able to see, then that's not the time for the swab wash to go, because I want to fill up the reservoir with a swab wash that can sit there waiting. So we will interchange between machines. We'll have lines, 3 suction lines, and we will start off with them dedicated to swab wash, abdominal, but we can move between them, if that makes sense. I think, is that fair to say, Anne-Marie? But we would never, and with the ACDA in the drapes, you can hold it in the slightly out of the operative field so you can see, but you can hold it before it's got to onto the machines without it clotting off. So I think that's the key, to get the ACDA into the drapes so that it can sit there for a while until you've got room to send it.
Okay, right. We've got a couple of minutes left. Another simple question for anybody to take on. Cell salvage in sickle cell trait, yes or no? Shruti, have we had any reports of problems with cell salvage with hemolysis or any other issues from following reinfusion?
Not specifically for the sickle trait. That has not been covered in any of the reports, so I wouldn't know. Okay.
Has anyone got any? As far as I know, the evidence is such that there isn't any evidence, and there are 1 or 2 case reports only, and the clearly perceived risk of hemolysis or sickling is very high. But then those patient groups are at risk of being very difficult to cross-match. So there is a really difficult situation until we've got the adequate evidence, and we're hoping that some research will be done shortly. So a next very simple question. In my hospital, how do I know how effective my cell salvage service is? How would I know if it could be better? I'm guessing the question really there is, how many red cells can I reduce transfusing, and how can I reduce the post-operative anemia issues? How do we get that? Has anyone done that? Anyone looked at that?
So I think go on, Ollie.
No, I was going to say, I mean, it's a really difficult question to answer. How effective is my service? You need really good data. You need some outcome data. Historical data is fantastic. You know, cell salvage is a wonderful intervention. And there are lots of other really good interventions in patient blood management. They're never introduced as a single entity. So trying to measure the effectiveness of just one component of patient blood management is really difficult. So historic data is great. If you can look at historic data and assess it to current data, that's fantastic. You've seen from some of the data that I've presented, we're looking at volumes that have been reinfused back to patients. But it's a really difficult, I think it's a really challenging thing to assess the effectiveness of your cell salvage service. But I think you can look at your data and try and make sure that you are streamlining it where possible to deliver it to the surgeries where it can be really beneficial, that you're not necessarily using it in areas where there is very low yield and low reinfusion rates. I would take that as a marker of a good quality service. Okay.
And one final question before I wrap up. Please, would you do the survey again? We need to know more. Well, I guess we will. But I think with the assistance of everybody and moving towards a minimal data set, we hope that everyone will be able to contribute to the data collection. And so we can make all our jobs a lot easier. And Shruti will, I'm sure, be very happy if we were to do that. So I would like to thank you all so much for attending this meeting. I'd like to thank you all for staying with us. I'd like to thank Tracy once again for helping set this up and facilitating and being so supportive of the UK Cell Salvage Group. I would like to thank Jane Murphy and Jimin for facilitating in the background today. And I would really like to thank our speakers for all the hard work and preparation they've done.